Assalamu alaikum wa rahmatullahi wa barakatuh. The case that I'd like to share with all of you is about there is a patient who referred to us as a case of the complete heart block. He is a 65-year-old Umrah Pakistani patient referred urgently from the Burial Hospital at the 3 a.m. as a life-saving case with complete heart block for BBM implantation with no known medical illness before. Upon arrival at our cardiac center, King Abdullah Cardiac Center, Quaternary Center in Mecca, as a life-saving, he was confused, disorientated, but conscious with baseline blood pressure 70/40 and heart rate 28 per minute, despite he was in intravenous dopamine infusion 10 mic per kg per minute and transcutaneous pacing during transfer to KMC as no TBM facility at the Burial Hospital. This is ECG upon arrival at the cath lab. Any comment from the panel?
Complete heart block with, I think there is an ST elevation in lead AVR, probably, which may be a clue for left main or proximal LAD or something like that, but there is a complete heart block.
So there's ST elevation in which problem is it? Is that in V1?
V1 and V2.
V1 and V2. So there's an antroceptal, maybe MI, yes, along with, yep.
Okay. Then immediately I bought, there is a pacemaker for him, and there is a pacemaker.
So he had absolutely no chest pain at the time?
No chest pain.
Just his main symptom is?
Confused, disorientated with shock status, with heart rate, it was very low.
Right.
That's why initially I bought, there is the pacemaker, which is through there is a right femoral vein, and it was pacing and capturing. But BB remains the same. It doesn't improve at all.
Right.
Then I proceed for both right femoral sheath to shoot the coronary artery. The problem, I tried to search where is the coronary artery. I couldn't find the coronary artery, but there is a GR. Then the thought to me, you can use another diagnostic catheter, or you can insert the balloon pump because he's in shock status. Then with the GR, I proceed, I do aortogram. I know it's not the ideal. I need to put, there is a swung, but I couldn't find the RCA.
Dr. Ayman, what was his hemodynamics after you put that temporary wire? Did he improve? Temporary wire, how was his hemodynamics after you put the temporary wire?
Hemodynamics is pacing and capturing. You can see the spike. But the blood pressure 70/40 doesn't improve.
74. Okay.
Okay, then I told them, give me, there is a guide to the left system.
Okay.
Because the patient is very critical and I lose the patient at any time. And this is 3 a.m. early morning. Okay. At the invasive cath lab, TBM was inserted at a suitable good position, but notes that there is a heart not contracted well, no adequate blood pressure achieved despite functioning of the TBM. Then immediately coronary angiogram by transfemoral approach was performed, and starting with right coronary angiogram, note there is no right coronary artery, even by aortogram. Then immediate left coronary angiogram was performed, which revealed total LED. You can see the stump of the LED in the two view. Then immediately I cross the wire to LED. Once I cross the wire, immediately the pacemaker functioning well, blood pressure improve, and the blood pressure is picked up. Yeah. Okay, this is the standstill pictures. Yeah, after that, I found there is a lesion in the proximal, there is the LED. I put the stent. After there is the mid-LED, I found the right coronary artery.
Maybe from the panel, Dr. Samih, you look amused. Can you share your amusement with us? What do you see?
I have not seen yet a right coronary coming from the LAD. I have seen the LAD coming from the right, but I have not seen this reverse. So I'm amazed, of course. It's a life-saving intervention and definitely excellent. but
In the LAD and the, is it a septal? Is it a septal?
No,
Is it coming from the septal area?
This is RCA, yeah.
it's not in the path of a septal. It's just a straight junction. That's it, straight from one side to the other.
Right.
Unusual origin for the right coronary artery.
It is.
At least continuity with the septal perforator from the LAD.
So his hemodynamics improved after you recanalized that LAD?
Yes. Immediately blood pressure becomes 140, 80. Heart rate will become 80 immediately. Even we need to stop the pacemaker. No need for it.
So the question is, this complete block, is it because of that RCA or is it because of that LAD?
Yes, yes, yes.
Alone?
Because the LED occluded, that's why they like two V's occluded, yeah.
Right.
Okay, there is a plan to do, there is a BCI to totally occluded the LED, and ABU guide was used, and cyan wire was across the lesion, pre-dilated with regular balloon, and once to open the LED, we notice pacemaker is capturing and pacing nicely, blood pressure picked up, immediately BCI to the proximal, and we found another lesion there, was performed, and the RCA was seen clear, originated from LED, which was occluded as LED was occluded and opened with the TB3 flow once LED was opened. The patient was maintained in TBM, post-successful BCI to LED for 24 hours, which was removed with sinus rhythm, stable general condition to continue his Umrah mission as he planned. Patient was reviewed after 1 month on the OBD clinic. He was doing well and stable status before he will go back to his country.
Maybe CT angio can visualize the anatomy very well to see the right coronary artery.
He's life-saving.
Later on.
Later on,
Yeah.
But I don't proceed because he's doing well, hemodynamically stable, electrophysiologically is doing well. That's why I stop up to that level.
So has anyone seen this kind of anomalous, Dr. Haytham? Can you talk to us about this? Can we have a microphone? وهناك في ناس بتلوح كذلك بس حموا الميكروفون قبل ما تعطوه لهذا الله يخليكم اضغطوا.
Yeah, I mean, we've seen one case like this, but it was an elective situation. So the patient came for a diagnostic angiogram, and it's very similar to that. So we really scratched our heads. But when you did the, RA or LAO views, you would see the right, coming out from the LA, but it was a stable patient. This was a really, really difficult case.
I think the difficulty here, again, is because of the fact that the patient is in shock. This is a STEMI. You don't have enough, you can't afford to fish around for that RCA for long. Dr.
Sam, we published 3 cases in 2013. It's in PubMed from National Guard and 15 years.
Of what?
Origin of RCA anomalous from proximal LAD.
From proximal LAD.
Yeah. Some of them acute and some of them elective. At least one of the lady, she was acute coronary syndrome, like typical acute.
Yes.
Thank you, Dr. Ayman, as well. There is an important point here to the value of CT angio to delineate whether this artery, this RCA looks like as if it's coming from the septal branch. But it actually cannot happen because this is an epicardial vessel giving at the same time the RCA, and the septal branches are perpendicular and dipping into the septum, because if you consider this septal branch, the RCA cannot fill. There must be intermittent systolic variation in flow. So the value of CT angio in the future, if this RCA have to be grafted, for example, you have to know where there is the ostium is not the septal. It's an epicardial branch.
That's great.